1 in 5 pregnant women suffer from gestational diabetes.
High body mass index, particularly more than 25, and being obese with a body mass index of more than 30 puts some.
What are the risk factors, doctor, as far as this? So, doctor, could you tell us a little bit about management of this kind of diabetes?
So that's a very good question.
Hello, Coimbatore viewers. 1 in 5 pregnant women suffer from gestational diabetes, and these women are mostly prone to type 2 diabetes at a later stage. So there are about 1 million cases in India that is diagnosed every year, and Tamil Nadu ranks number 2. So what exactly is this gestational diabetes? So we will be talking to Dr. DrpremalathaN of the Royal Care Hospital, who is an obstetrician and a gynecologist with special interest in high-risk obstetrics. Let us talk to her. Thank you so much for talking to Coimbatore, doctor. So gestational diabetes among pregnant women. So could you tell us about the diagnosis?
Hello, Coimbatore viewers. It is indeed my privilege here to be with all of you to talk about gestational diabetes. Gestational diabetes is a condition which is diagnosed during pregnancy, wherein women develop abnormal glucose levels diagnosed for the first time when they are pregnant. And what makes women prone for this condition? There are certain factors. We being in the diabetic capital of the world, being South Asian, particularly South Indian, puts us at a very high risk factor for developing this condition. And high body mass index, particularly more than 25, and being obese with a body mass index of more than 30 puts someone at an increased risk for developing gestational diabetes. And having had a polycystic ovarian syndrome diagnosed during the early teens or in the 20s also puts women at an increased risk to develop gestational diabetes. And more importantly, if the woman has had a previous history of having delivered a baby weighing more than 4 kilograms, that is, we call that a macrosomic baby, then she is at an increased risk of developing gestational diabetes.
Okay. So, doctor, what should these women do? I mean, how does a woman brace herself to this kind of diabetes? Does this run in the family? Is it hereditary?
Yeah. Gestational diabetes is something that can run in the families. It is a small warning that this women could later develop type 2 diabetes.
Right.
It is a condition associated with insulin resistance.
Okay.
It is something more to do with their lifestyle, like being obese puts someone at an increased risk for this condition.
So which obviously means that every other lifestyle related disease, diet and exercise plays a vital role.
Absolutely, absolutely. Having an optimal weight before falling pregnant can perhaps reduce the risk of developing this condition. It's quite important that women attend to preconceptional counseling, wherein they can discuss with their obstetrician about the various things that they could encounter in the pregnancy depending on their medical risk factors, their age, their general health, their partner's health, their family history, and so on.
Okay. And what are the risk factors, doctor, as far as this gestational diabetes is concerned?
So that's a very good question. So we divide the risks broadly into 2 types. One is the fetal risks, which is the risk for the baby, and the other is the maternal risks, which is the risk for the mother. Coming to the fetal risks, so if a woman has pre-existing diabetes, then there is an increased risk for congenital malformations, that is structural malformations in the baby. There is an increased possibility of that.
Okay.
So more importantly, this malformation affect the neural system, central nervous system, and the cardiovascular system.
Okay.
And women are also at increased risk of miscarriage, losing their babies, increased risk of preterm delivery, increased risk of stillbirth, that is, the baby may die during the later stages of pregnancy, particularly if the blood sugars are not well controlled.
Okay.
And one important risk, which is quite unique to gestational diabetes, is what we call macrosomia, that is, the babies can become heavy.
Okay. Warranting a
and,
cesarean only.
not necessarily. We can give a safe trial for a vaginal delivery, but then macrosomic babies do put the mother at an increased risk for a cesarean delivery.
Right.
And more importantly, these babies have increased pad of fat in their shoulders. So even during a normal delivery, we can encounter a potential condition called shoulder dystocia, in which there is difficulty in delivering the shoulders of the baby. So this is quite unique to gestational diabetes.
Okay.
And once the babies are born, they are at increased risk of metabolic complications like hypoglycemia, which is low blood sugar levels, and other metabolic complications like hypocalcemia and hypomagnesemia.
Okay.
So these are the risks for the babies. Coming to the risks for the mother, if the mother has pre-existing diabetes and she's someone who already has some complications related to the pre-existing diabetes, which might have affected her eyes or kidneys, these complications could perhaps worsen during the pregnancy. And women are at increased risk of operative delivery and needing an early induction of labor for various reasons. And once we initiate treatment to control the blood sugars, hypoglycemia is another risk that we can encounter. So we have to warn her about the potential risks of hypoglycemia, as well as the symptoms that could perhaps help her detect that she could be hypoglycemic. And these women are also at increased risk of developing a condition called preeclampsia, where there is an increased blood pressure as well. So this and gestational diabetes is not a good combination, really.
Okay.
So these are the maternal risks.
Okay. So, doctor, is there any testing or screening where you could subject these pregnant women to, well before, so that you can manage it accordingly, or only a diagnosis of gestational diabetes and then you can start the treatment? How does it go?
Okay, sure. So once the pregnant woman comes to us for her first antenatal visit, once she has confirmed her pregnancy, we generally do a random blood sugar and HbA1c. HbA1c is glycosylated hemoglobin, which gives us an idea of her blood sugar levels over the preceding 3 months. So if a woman has a HbA1c of more than 5.5, then that is a small indication that she could perhaps develop gestational diabetes later in her life.
Okay.
And this test also helps to detect the previously undetected type 2 diabetes.
Okay.
They are not gestational diabetic, but they are type 2 diabetics, probably who are not diagnosed and diagnosed just because they fell pregnant and had a blood test.
Okay.
So it helps in differentiating that. So this test is really important. If this woman has had a previous history of gestational diabetes, even though these tests may be normal, it's quite important to do a test called a glucose tolerance test at booking itself.
Okay.
A glucose tolerance test is a test that is done to see how the body handles sugars.
Okay.
It would involve an overnight fasting of about 6 to 8 hours. We do a blood sample at fasting. Then
you do when she's pregnant? Fasting of 6 to 8 hours?
That's right.
Wouldn't it affect the...
So we would recommend an overnight fasting and advise the women to come first thing in the morning.
Okay.
She can even come as early as 6 a.m. Our lab is open.
Okay.
And she can give the fasting blood sample.
Okay.
Then we give her a measured amount of sugar, that's 75 grams, and then do a blood test 2 hours later. Okay. So this will give us an idea of how her body is handling the 75 gram sugars. So this is what all the universal bodies recommend to detect gestational diabetes.
Okay.
A fasting value of more than 90 and a 2-hour glucose challenge value of more than 140 is diagnostic of gestational diabetes.
Okay.
So for women who have a normal HbA1c and a random blood sugar at booking, we tend to do the glucose tolerance test somewhere in the mid-trimester.
Okay.
The mid-trimester, that is the second trimester of pregnancy, is between 12 to 28 weeks.
Okay.
So depending on other risk factors in the women, as in body mass index, previous history of PCOS, so we subject them to glucose tolerance test at some point in the mid-trimester.
Okay.
But even if the glucose tolerance test comes as normal, even in the as late as the 3rd trimester, if the women show some signs or findings which could perhaps suggest that she's developing a late gestational diabetes, then the doctor has to be quite vigilant in picking that up because it has various implications on the mother and the baby.
Okay. Okay. So, doctor, so when we were talking about obesity, so you said obesity is one of the factors for gestational diabetes. I mean, does it
Absolutely.
work the other way also? The woman comes with a normal weight but tends to gain weight later because of gestational diabetes.
Yeah, I mean, gestational diabetes is more diagnosed in women who gain excessive weight during their pregnancy.
Okay.
But once we diagnose gestational diabetes and we initiate the appropriate management, which is a strict low glycemic diet and sometimes medications and insulin, then the weight gain tend to be less, honestly. So it is, the converse is true, perhaps.
Okay. Okay. So, doctor, could you tell us a little bit about management of this kind of diabetes?
Absolutely. So gestational diabetes is managed as a team. So we need an obstetrician, we need an endocrinologist, and we need a dietitian. So diet and exercise forms the main factor. So we advise women to have a low glycemic diet and undertake at least 30 minutes of exercise in a day. So depending on their blood sugar levels, if it is not too high at diagnosis, most women can be managed by diet and exercise alone. But if this doesn't work for the first couple of weeks, then we initiate the medical therapy. Metformin is the drug that is commonly used, which is safe to be taken when women are pregnant, and it helps in optimizing the blood sugar control. For women in whom the diet and metformin hasn't helped in achieving the blood sugar control, then we would have to perhaps go for insulin injections. Okay. And it is very important the women do their blood sugars, check their blood sugars at least 4 times a day, fasting, post meal, after breakfast, after dinner, and after lunch. So they would aim to keep the fasting to less than 90. They should aim to keep the 2-hour post meal to less than 125 and 1 hour post meal to less than 140.
Okay.
So it's very crucial that they maintain their blood sugars within these strict limits to avoid the potential complications. Okay. And for women who are managed by diet alone, they can be allowed to go close to their due date. But women needing medical therapy with metformin, we normally should not exceed their pregnancy to go beyond 39 weeks. So we recommend something called an induction of labor at 39 weeks.
Okay.
Because diabetic pregnancies have an added risk as compared to
The
normal
normal
pregnancies, in which the placental function decline happens pretty quickly in the later gestation. So that is something that can lead to stillbirth.
Okay. So which means if I'm getting it right, it kind of prohibits the food inflow to the baby?
Sort of. Once the placental function declines, then the nourishment to the baby is affected. So it could perhaps compromise the baby. So that's the reason we tend to induce them early. And if they end up needing insulin, then we should not allow the pregnancy to go beyond 38 weeks. Okay. And diabetes in pregnancy is not an indication to go for a cesarean section straight away. So it all depends on other obstetric factors as well. When these women go into labor, they need something called a continuous electronic fetal monitoring to monitor the heartbeat in labor. And they are okay to have the normal pain relief options as in Entonox, epidural, or any painkiller injections.
Okay.
And cesarean section is purely for obstetric indications only, and not just because the woman has gestational diabetes. And a fair share of women do have vaginal deliveries.
Okay.
And they would need, once the baby and placenta are out, the blood sugar normalizes. Okay. So the insulin and metformin can be stopped, but these women have to have a glucose tolerance test again at 6 weeks postpartum, and they should be advised about lifestyle management to continue for the rest of their lives to prevent the development of type 2 diabetes.
Okay. So one quick and a last question, doctor. Just because the woman does not develop gestational diabetes during her first pregnancy, it does not mean that she won't develop during the second. And also, if she develops during the first, would she have it during the second as well?
Okay, that's an excellent question. For women who have had gestational diabetes in the previous pregnancy, most of them tend to develop in the subsequent pregnancies as well, unless they have lost a significant amount of weight and adhere to strict diet. And the converse is also true for women who have not developed gestational diabetes in the first pregnancy. Maybe the interpregnancy interval may be long. They might have put on weight, so they might develop it in the second pregnancy also.
Okay.
So we should offer screening for all pregnant women, no matter which background they come from.
Okay. So thank you so much for talking to the COVID post doctor.
Thank you so much to you, and thank you, COVID post, for this opportunity.
Thank you.